The mission of Scott Care Cardiovascular Solutions is to provide hospitals and cardiology practices with the highest quality cardiac diagnostic monitoring devices, software, and expert clinical monitoring labor. We're proud to make the following presentations available to the cardiovascular community. These presentations were recorded live on May 4th, 2016 at the 37th Annual Scientific Sessions of the Heart Rhythm Society in San Francisco. We thank Dr. Suneet Mittal and Martha Ferrara, both of Valley Health System, for their time, passion, and dedication to sharing best practices for effective remote monitoring. Our first segment is presented by Dr. Suneet Mittal of Valley Health System in Ridgewood, New Jersey and New York, New York. Dr. Mittal is board certified in cardiovascular disease and clinical cardiac electrophysiology. His presentation today includes discussion of the history of remote monitoring for cardiac implantable electronic devices, as well as related and ongoing research regarding the contributing factors and obstacles to monitoring success.
David, thanks very much for the kind introduction. I really want to thank Scott Care for taking the initiative to sponsor, I think, a very important session today, which is really trying to understand where we are with remote monitoring of patients with implantable devices, and really talking about how we manage the transition to the new guidelines to ultimately improve patient compliance and patient outcomes. So remote monitoring has evolved quite a bit, but interestingly, there is no field more facile with remote monitoring than the field of cardiology. In fact, devices have been implanted for more than 50 years, and as long as devices have been implanted, we have been trying as cardiologists to remotely follow our patients in some way. In fact, since the early 70s, transtelephonic monitoring was made available for the follow-up of pacemakers, and although the technology was quite crude and remains quite crude, has really served as the benchmark against the way we follow these patients without having to come to the office. The field stayed that way essentially unchanged till 2002, at which time essentially remote follow-up was released in the US. And what remote follow-up was, basically patient would use a wand, much like we use in the office, to basically on a quarterly basis interrogate their device, and the data would then be sent to the office for further review. And again, now you could get information not only about the battery, information about sensing and capture, but most importantly, the first time we started to get the ability to review the important device diagnostics that were being stored within these devices. The field then really took a forward leap in 2005 with the release of fully automated wireless devices, which then allowed us, the patients, to be removed from the process other than ensuring that they were basically connected to the remote monitoring system. As these systems were released, we also had the ability to start to follow parameters for heart failure. And then finally, I will add, and I'll show you some data to support this a little bit later. You know, I would argue that the field has then taken another iteration forward just 2 years ago with the release of the Link implantable cardiac monitor, which now gives us a wealth of data on a daily basis in patients being monitored long-term for known or suspected atrial fibrillation, cryptogenic stroke, or unexplained syncope. Now, since the release of remote follow-up in 2002 and then the subsequent evolution of remote monitoring in 2005, the promise of remote monitoring has stayed the same. And in general, physicians have been interested in 4 basic types of device functionality. We wanted to really know what the generator is doing. We want to know what the leads are doing. We want to have information about arrhythmias, especially atrial fibrillation and ventricular arrhythmias. And increasingly, there's a desire to get information about heart failure diagnostics. And over the last decade, a tremendous amount of data has been accrued with respect to remote monitoring. And today, in the interest of time, I'm going to really highlight some of the more recent data and some of the more high-level data that support the routine use of this technology in our patients. Well, probably no more important endpoint is that of survival, and there's been a great deal of interest in trying to see whether there's an association between, one, the use of remote monitoring and survival, but then more recently trying to understand whether there's a relationship with adherence to remote monitoring and survival. And finally, there's interest in trying to understand whether the benefits of remote monitoring are specific to a particular type of device, namely, are these benefits limited to patients patients with ICDs or CRT devices, or do these benefits also extend to low-power devices such as pacemakers? So the most recent attempt to address this question was this study that we published last year, a very large mega cohort study of nearly 265,000 patients. Patients were implanted with either a pacemaker or defibrillator capable of automated wireless data transmission. Patients were then followed, and patients were divided into three groups of patients. You see one group of patients, which remarkably still represents more than half of all patients implanted with a device, were those individuals who were implanted with a device, but their physicians chose not to engage them with remote monitoring. Then of the other half of the population that did enroll in remote monitoring, we further divided the cohort into those individuals who were adhering to remote monitoring for a high portion of the time and those individuals for low portion of the time. And in this case, how we defined those was that if you were connected to your remote monitoring server more than 75% of the time in a given year, that you were adherent at a high level, and if you were less than that but still enrolled, you were at a low level. And then we followed these patients to an endpoint of total mortality. Now, these are the Kaplan-Meier curves that look at the follow-up of these patients over 4 years of time. Shown in green are those patients enrolled in remote monitoring and adherent to remote monitoring more than 75% of the time. Shown in blue are those individuals who are enrolled in remote monitoring, are adherent to remote monitoring, but not to the same magnitude as the cohort in green. And shown in red are those individuals who have a device that's fully capable of remote monitoring, but for whatever reason, the physicians chose not to enroll these patients into remote monitoring, or the patient chose not to engage with remote monitoring, and they're shown in red. And what you see here are staggering differences in survival. For one thing, when you compare those individuals who were not enrolled in remote monitoring, those individuals who were in remote monitoring and using it most of the time had more than a twofold increase in survival. Even individuals who were using it a lot did better than those individuals who were using it just a little bit. And frankly, if you were going to use it just a little bit, you were still doing better than not using it all, really behooving the fact that there is really an important association between high compliance with remote monitoring and long-term survival. Now, in the United States, as you know, and not to be a nihilist, mortality is not as important as used to be. What people want to know is what is it doing for healthcare utilization? And to try to address this question, John Pacini, Neeraj Verma, and I had the opportunity to again look at a large cohort of patients. In this case, nearly 200,000 patients who were implanted with a device capable of remote monitoring over a 5-year period of time. And there's some, before I even get to the data, there are just some incredible lessons as to where we are in the healthcare system and where we are with respect to the follow-up of these devices. So the first thing, which is just incredible, is that if you look at 280,000 patients, the first thing we wanted to ensure was the patient had the same health coverage for the 1 year prior to enrollment and 1 year prior to device implantation, and then 1 year post-device implantation. Remarkably enough, in the United States, in a contemporary cohort of the 280,000 patients we started in, nearly 125,000 patients dropped out because they simply don't have the same healthcare coverage 1 year before or after the device implant. Then you get to a cohort of 155,000 patients implanted in the United States, and we wanted to ensure that all patients were seen by a physician within the first 120 days of device implant. And it's really staggering to see that 60 out of these 155,000 patients after device implant in the United States are never seen by their physician after device implantation, which is just incredible. We then looked at the remaining cohort of 92,000 patients, and we divided those cohort of individuals who were enrolled in remote monitoring versus those that were not. And again, you see that of the overall cohort, only about 40% of the cohort was enrolled in remote monitoring, whereas again, in a contemporary cohort, 60% of individuals are still not engaged with remote monitoring. Well, when you look at some of the hard endpoints that contribute to healthcare use, you see that there was an 18% reduction in the likelihood a patient would be hospitalized for any reason when that individual was engaged in remote monitoring. And this translated over the course of the patient's lifetime to nearly 3 less days spent in the hospital. And irrespective of whether you look at it by a pacemaker, an ICD, a defibrillator, or a CRT pacemaker, this effect was fairly consistent. And overall, there was nearly 30% less healthcare utilization, largely driven by a significant reduction in hospitalization costs. And in fact, if you put this in another way, our data suggests that if you had 100,000 patient years of remote monitoring in the United States alone, we would have 10,000 fewer hospitalizations, 120,000 fewer days spent in the hospital, and a staggering $370 million saved annually to the healthcare budget simply by people keeping patients out of the hospital. We further extended this analysis to assess the impact of how important is it to get patients enrolled in remote monitoring as soon as possible after device implantation. So in this analysis, we looked at a large cohort of individuals who were all enrolled in remote monitoring. The only difference was that the group in purple were enrolled in remote monitoring within 90 days of device implant, and the group in orange were enrolled in remote monitoring, but enrollment occurred more than 90 days and less than a year after device implantation. Again, when you look at the follow-up of these individuals, and these patients are now followed for nearly 2.6 years of time, over 100,000 patients, you see that the survival curves start to diverge very quickly after device implantation, such that the group of individuals who are enrolled more than within the first 90 days of device implant have an 18% greater survival than those individuals with delayed enrollment in remote monitoring. And so I think that when we put these data together, I think there's a lot of rationale for concluding that what the recent HRS expert consensus document has stated is quite accurate. And specifically, the document makes 3 very important recommendations. Number 1, that all patients with a CIED should be offered remote monitoring as part of the standard follow-up management strategy. And this is class 1 level of evidence A, the highest level of recommendation one can deliver. Similarly, a strategy of remote CIED monitoring and interrogation combined with an at least annual in-person evaluation is recommended in preference to a calendar-based schedule of in-person device evaluation. So no longer are the guidelines saying that you have the option of doing one or the other, as was the case with the 2008 guidelines. What the guidelines are really saying is that unless you're getting an alert, there's really no reason why a patient should be coming in for a routine device check just to be told that their device is working entirely normally. And finally, importantly, based on the data I just showed you, the guidelines suggest that it may be beneficial to initiate remote monitoring within 2 weeks following device implantation. So how does that look like graphically? So here's a schematic of an individual in which the patient undergoes device implantation. The guidelines suggest that within 2 weeks of device implantation, the patient have an in-person check to look at the wound. And basically then the follow-up starts, where shown in blue are quarterly bullets where a device is interrogated remotely. In between, if you have an alert for ventricular or atrial arrhythmias or a heart failure exacerbation, of course, you should bring the patient to be seen for further evaluation, but an in-person check should be limited to just once a year. Now, the data and the guidelines are very clear, but what is also very clear is that we're doing a very poor job of following these guidelines. So here's some data that show like what is happening in the real world in the United States with acceptance of remote monitoring on the part of patients and the part of physicians. So these are data that Medtronic shared with us in 2010 that my friend and colleague Dr. Moskowitz and I took a look at, where we had 175,000 patients with a Medtronic defibrillator that was capable of automated wireless transmission. And the first thing we see is that of the 265,000 patients that were enrolled, only 175,000 patients were enrolled by their physicians into remote monitoring. So essentially, 2 in 3 in 2010 were being enrolled in remote monitoring. Then, as I've mentioned to you, the guidelines suggest that a patient should transmit or be compliant with remote monitoring at least on a quarterly basis. And on the right, you see, what was the compliance schedule based on the patients. And it was remarkable to see that, a quarter of individuals never transmitted, not once. And in fact, our desired goal being a quarterly transmission was observed in only about 6% of patients. So incredible degrees of non-enrollment and non-compliance. Now, you may say, well, these are data from 2010, and we weren't as sophisticated in 2010. And of course, we've gotten a lot better because we've now greatly learned the value of remote monitoring. Well, we wanted to see that, and actually we looked at the data, same set of data, 3 years later in 2013. Of course, now instead of 275,000 devices, there are 1.3 million devices. But look what happens to enrollment. In 2010, we were enrolling 2 in 3 patients. In 2013, we were down to 1 in 2. And look what happens to the patient level data. In 2010, 1 in 4 patients never transmitted, but by 2013, there was 1 in 3. And if you look at the desired goal of quarterly remote monitoring, we went from 6% down to 2%. So we're actually headed in the other direction as opposed to the way we want to go. Now, why is that? Well, the first thing to get patients enrolled in remote monitoring, the physician has to actually engage the patient in remote monitoring. And this is wonderful data that Joe Acker at Yale and his colleagues did, where they looked at the Boston Scientific Altitude database to try to determine what is the single most important predictor of how a patient gets enrolled in remote monitoring or not. And disappointingly, it turns out that the single most important determinant is the hospital at which the device is being implanted. So there are certain hospitals who enroll virtually everyone in remote monitoring, and there are other centers that enroll virtually no one in remote monitoring. And it turns out in a separate analysis we did, this tends to be incredibly geographically based. So one could argue, one would think, well, probably patients living in major metropolitan areas, the doctors are more likely to enroll their patients in remote monitoring, and maybe it's just, in other parts of the country, this information hasn't disseminated, and therefore these patients are not being enrolled. But in actuality, the data are just the reverse. So what you're seeing here are basically 2 things. The first is you concentrate on the size of the circle. The size of the circle tells you in the particular zip code how many patients are being covered or being followed in a clinic remotely. And then the colors of the circles tells you of that total population being followed, what is the likelihood that they're either adherent at a low level in remote monitoring, shown in red, or high, shown in green. And what you see is that the people who do the worst are all those populations where there's a lot of people living. So California, Chicago, the Northeast, Florida, dismal rates of of enrollment, and yet these are the regions where most of the patients in remote monitoring are followed. And in fact, a lot of credit goes out to our colleagues in the Pacific Northwest and the Midwest, where they're doing a much better job in managing these patients remotely. So then the question becomes, why is this? Why or is it that there's so much resistance to getting patients onto remote monitoring, and why are patients not engaging in remote monitoring? So several years ago, Martha and I had the opportunity to look at this, where we essentially did a deep dive into our patient population to try to understand, why is it that patients don't enroll in remote monitoring? And you see here are the 5 biggest reasons we found that patients did not enroll, and these included just the technology was overwhelming. They could not understand the difference between remote monitoring and follow-up. Their cardiologists felt it was not necessary, and occasionally patients have language barriers. But by far, the most common reason why patients did not enroll or engage with remote monitoring, they just found the technology, very complicated. In fact, I was at a presentation earlier today by Dr. Mehta at the Sanger Clinic, and they've looked at their experience and found exactly the same thing, which begs the question, why we don't have more plug-and-pay types of systems that would make it easier for our patients. Now, where this has become even more complicated is in the past 2 years with the release of the Medtronic Link implantable loop recorder, which gives the opportunity for daily ECG monitoring. And this is a device that's being increasingly used, as you know, in patients with cryptogenic stroke, syncope, as well as for atrial fibrillation management. And in a very short period of time, what this device has done is started to really overwhelm our practices in the amount of data that's coming in. So this is a slide I put together showing you essentially what has happened over the last 4 years. So the Link was essentially released in late February, early March of 2014. And prior to 2014, we had other forms of implantable cardiac monitors that were non-wireless. And consistently, in the 2 years prior to the release of the Link, only 20% of all our remote transmissions were related to the implantable cardiac monitor. But you see really how quickly the Link can start to overwhelm your practices. In 2014, this accounted for already 44% of all of our data transmissions. And by 2015, last year, more than 60% of all data coming into your office was basically dealing with Link devices, and we suspect that this will probably continue to grow in time. And so what this really tells us is that we need mechanisms to deal with the data. So what are the challenges? Well, the first thing is, again, Colin and I had the opportunity to look at this several years ago and try to break down all the areas where this process can go astray. And the first is there's a need to educate the patient so that they engage with and believe in the importance of remote monitoring. And this takes time because the initial education process that we have to do, but often falls on our allied health professionals, is they have to explain the utility of a follow-up. They've got to really do a good job of differentiating the differences between in-office and remote follow-up. They need to explain to patients how often we're monitoring these devices. Again, explain the differences between remote monitoring and remote interrogation. Everyone needs to understand what their roles in the process are. We've got to ensure that a patient is an appropriate candidate for this technology. And then more and more, we've got to determine, how do we match the right technology to the right patient so the data communicates with ease. Now, once the patient is enrolled, well, that's only half the battle. The next battle is to ensure that they remain connected with the system and adherent to the system. And this is important because, as I've shown you, this translates into significant differences in survival in the patient cohorts. And so there are many steps in this process. The first is from the time you enroll the patient, the very first thing you've got to ensure is that they're actually connected to the system. So we make sure we enroll the patient in the remote monitoring. We make sure that the patient receives the remote monitoring system, and many hospitals now give the remote monitoring the system to the patient before the patient leaves the hospital after device implant. And then you've got to really have a process in place that ensures that from the time the patient leaves or receives the remote monitor, that you have then received the first transmission, because it's been conclusively shown that once you can establish that first handshake transmission, that then the likelihood that that patient will remain on the system increases dramatically. We try to get data from our wireless loops daily, monthly from our heart failure patients and other forms of implantable monitors, quarterly from pacemaker and defibrillator patients, and then, of course, all along this way, you have to have a robust system to identify those individuals who may be falling off the grid for one reason or the other. And the reasons can be quite varied, including, the cable provider made a change in their system internally, and all of a sudden, the system is no longer transmitting any data. And finally, once you get the data, you got to communicate the data to someone. So the electrophysiologist has to know about alerts. You got to know what is significant alerts. And then at some level, someone has the responsibility of making sure all the healthcare providers involved in the patient's care basically get that information. So this is a pretty daunting process. And really the $64,000 question in my mind is, how do you best accomplish this process to achieve a successful outcome? And I would argue that there are three ways that people have tried. And I will tell you, where these programs may have advantages and where they may have disadvantages. Well, the first that almost everyone tries is that they look to their Martha and they say, Martha, handle my remote monitoring. And you just basically append that responsibility to their already existing responsibilities. You just assume that they can basically take care of this, and you assume it's getting done. But we really saw that this is really not humanly possible. In fact, a couple of years ago, we investigated how good was this do-it-yourself model. And in fact, we divided our cohort in 3 groups of patients. We looked at patients with a pacemaker that were being followed quarterly, ICD patients followed quarterly, and loop recorders that were being followed monthly. And what you see in blue is how many device checks we would have produced remotely if we were 100% compliant with our remote monitoring schedule. Shown in red is actually how many we did. And this is not because the nurses aren't working hard enough, they weren't paying attention to it. It's simply not possible. There's only so fast, a hamster can swing, go on a treadmill, and this is just an overwhelming process. It is extremely difficult to keep hiring the staff internally necessary to get and bridge this gap internally. Now, the second way you can do it is what's been tried in Europe. And in Europe, what's been tried is where they create central monitoring centers. So basically, there's a central monitoring center that's created, and many different hospital systems basically use that central monitoring system to basically funnel in the data. And so what you see in blue are all the alerts that are coming into the central monitoring station, and those monitoring stations then basically triage those alerts, and only a small fraction of those alerts, basically shown in red, are moved forward to the physician for further evaluation. Now, this, I think, is a great concept in Europe, but as you know, in the United States, there's some challenges with having different hospitals work together in this area when they are not tied to the same health EMR system. They're seeing different cohorts of patients. So this has been a challenging model to use in the U.S. So the model that we really believe in and believe that really has a lot of role is using really a third-party device and patient management vendor whose job is to really sit between your practice and all of these patients who are being remotely monitored to ensure that all of these steps along the way are being done. And in fact, we've just been really blown away by the success of this model. So what you see here showing our data for 2012 in blue, 2013 in red, and in green 2014 for our practice once we've gone to this type of model. And what you see is that when you look at the second group of columns, the number of patients that we implant that are enrolled in remote monitoring are nearly 100%. Far cry, from the 50% or less that's seen nationally. And more importantly, if we look at the third column, the number of patients who never transmit is not 25 or 35%, is less than 2%, which is just the reverse of what's seen nationally. And in fact, when we look at the number of patients that are transmitting more than 2 times a year, we're over 90%, which really, helps us address this area. Now, why is this important? I think it's important because ultimately this is going to be available as a publicly reported measure. I mean, I think soon the day is coming when we will be evaluated as physicians, both on how we're programming these devices, because that has implications for the outcomes of the patient, and exactly showing how well we're doing engaging with our patients in remote monitoring. And this will allow patients to compare physicians with respect to evidence-based implants, what their complications are short and medium term, and look at whether there are differences in between physicians and their rates of inappropriate as well as appropriate ICD shocks. Finally, I think this will be an opportunity to compare vendors with respect to device longevity, the integrity of their systems, as well as their outcomes. So, ladies and gentlemen, I hope I've convinced you that really change is difficult, but not changing is fatal. I think this is really apropos in this space with remote monitoring. I think the days of relying on quarterly in-office visits to determine how well the patient is doing with respect to their device are really yesterday's news, and I think that's in the rearview mirror. I think what is very clear is that an alert-based remote schedule of follow-up of these patients is really here to stay, and what we really all need to wrestle with is what's really going to be the best model in our practices to ensure that everyone's enrolled in remote monitoring, and once enrolled, that they are adhering to this at a high level so that we can garner the maximum benefit for these patients over the long term. Thank you for your time and attention.